All right, let's go through this case. We're looking at an arterial phase CT of the abdomen, and the standout finding is a transection of the pancreas at the junction of the body and tail. There's a clear separation of about 2.5 centimeters between the two components. Importantly, the rest of the pancreas enhances normally, and there's no evidence of pancreatic calcification or gallstones on this study. There's also a 15-centimeter fluid collection located anterior to the pancreas. This collection extends from a cleft within the pancreas and displaces the stomach anteriorly and the splenic vein posteriorly. The splenic vein appears patent, which is a good sign. The liver and spleen show some heterogeneous appearance, but this is likely due to the arterial phase of the scan rather than actual pathology. Other observations include a small left-sided pleural effusion and left basal atelectasis, which are likely reactive changes. There's no free intraperitoneal gas, no free fluid in the abdomen, and no fluid in the mesentery. Additionally, there's no evidence of other solid organ or acute bony injury. Putting this all together, the findings are consistent with major trauma resulting in a traumatic pancreatic transection. The large fluid collection anterior to the pancreas is most likely a pancreatic pseudocyst resulting from the injury. There's no evidence to suggest other intra-abdominal injuries, and the splenic heterogeneity is likely related to the phase of the CT rather than trauma. Differential diagnosis includes a pancreatic pseudocyst from prior pancreatitis, but there's no imaging evidence of previous or recent pancreatitis, and no gallstones are identified on this study, which makes this less likely. In terms of management, an urgent upper GI surgical opinion is critical. This patient is at risk of developing traumatic pancreatitis, and the fluid collection could potentially be managed with endoscopic ultrasound-guided drainage into the stomach or CT-guided external drainage, depending on the clinical scenario. From a radiological perspective, reviewing a portal venous phase CT would be important to confirm the patency of the portal vein and assess for normal splenic enhancement. In summary, this is a case of traumatic pancreatic transection with a large associated fluid collection, likely a pancreatic pseudocyst, but no other significant intra-abdominal injuries. The management requires a multidisciplinary approach to address the risks of pancreatitis and potential complications. If you find this case informative and enjoy learning about complex imaging scenarios, don't forget to subscribe to our Radiology Made Easy channel. Turn on notifications so you never miss an update, and good luck with your studies and exams.